Hello, everybody. This is Jonathan Winston. I'm very pleased to be here, and thank you for allowing me to participate in this presentation. Today I'm going to talk about kidney disease and HIV, and I'm going to specifically address the spectrum of kidney disease that commonly occurs in HIV infection, the long-term risks for kidney disease in HIV, the issue of whether viral replication affects kidney function and induces kidney disease, and the interaction between the antiretroviral regimen and kidney dysfunction. The first slide reminds us of the nephron structure. Please remember that the kidney is a very vascular organ. You can see on the top of the slide the glomerulus, and the diseases that actually affect the kidney are usually vascular diseases. Hypertension and diabetes in the general population are the major causes of kidney disease, and that's the same situation in HIV infection. And as you know, we measure kidney function by assessing the rate of glomerular filtration using serum creatinine. We also assess for kidney damage by looking for protein in the urine, which also occurs by leakage of protein from the glomerular microcirculation into the tubule structure. A couple of interesting things that are new, the marker of GFR that we use clinically, serum creatinine, used to be considered a pretty accurate marker. But now we know with new drugs such as cobicistat that there's a component of serum creatinine that travels from the blood into the kidney, not through the glomerulus, but across the renal tubule cell. So that contributes to creatinine clearance, but doesn't actually reflect GFR. And cobicistat blocks this tubule secretion. So you get an increase in serum creatinine without a change in GFR. That's very important. Other drugs do that. We all know about cimetidine, Bactrim. There's evidence that ritonavir does it, and there's evidence that the new integrase inhibitor dolutegravir may do it. And I'll discuss more of that later. Chronic kidney disease is defined as kidney damage or reduced kidney function that lasts about 3 months or longer. And this slide demonstrates how we stage kidney disease, and we stage it according to the magnitude of reduction in GFR. So normal GFRs are GFRs that are greater than 60 ml per minute. If in that situation one meets criteria for kidney disease if there's protein in the urine. The cutoff between normal and abnormal GFR is arbitrarily set at 60 ml per minute. And that's actually based on some reasonable evidence, as shown in the next slide. This is data that shows event rate, either all-cause mortality, cardiovascular disease, or all-cause hospitalizations in 1 million people living in San Francisco and Northern California, all of whom are insured by Kaiser Permanente. And these investigators tapped into the Kaiser Permanente dataset and looked at serum creatinine in these 1 million people, estimated GFR using the MDRD equation, and then looked at the dataset to look for any outcome of interest, mortality, cardiovascular disease, and or all-cause hospitalization. And as you can see, as there was a decrease in GFR, there was an increment in adverse events. And that began at or around the break point of 60 ml per minute, where event rates increased by 20%. And by the time GFR reaches at or around 15 ml per minute, the risk of an adverse event increases 4 to 6-fold. How do we measure kidney function? Well, the ideal marker of kidney function, or GFR, the gold standard, is inulin iothalamate, or iohexol. These are small molecular weight substances that are filtered at the glomerulus and not handled by the renal tubule. In clinical practice, creatinine clearance and serum creatinine are pretty reliable estimates of GFR. We can estimate creatinine clearance by serum creatinine using one of several formula. We all know the Cockcroft-Gault formula, and there are two newer estimates of GFR, the MDRD or the CKD epi equation. Importantly, these are the equations that you'll get in a readout from your lab when you send the serum creatinine. The other important marker of kidney damage is simply a urinalysis to look for proteinuria. We can look for proteinuria also by checking a microalbumin creatinine ratio in a spot specimen of urine. This is a standard of care for risk assessing kidney disease in diabetics. The usefulness of microalbuminuria in non-diabetics is still somewhat controversial, and there are very few recommendations to screen all comers for microalbuminuria. In terms of proteinuria, we used to do a 24-hour urine to quantify daily protein excretion. More convenient is a simple spot urine where you measure protein and creatinine and normalize the urine protein for the amount of creatinine in the urine. The next slide is an update of the classification scheme for chronic kidney disease, and it puts more balance and insight into the whole relationship between kidney dysfunction and outcomes. So it's a somewhat confusing three-dimensional slide, but let me take you through it. This is a compilation of many large-scale observational studies that looked at kidney disease in association with some adverse outcome, usually all-cause mortality, cardiovascular events, or hospitalization. And that's termed risk on this slide. And in the figure on the left, you can see that as you go from normal kidney function, stage 1, to very low kidney function, stage 5, the event rate goes up. But that event rate is also determined by the amount of protein in the urine. So people with heavy proteinuria, the third column in this slide, have high event rates even at normal GFRs. And people with very low amounts of protein in the urine don't tend to have event rates until GFR is very low. Now, why would that happen? It seems to me that the reason this occurs is because the population of patients who have heavy protein in the urine is by definition enriched in people with severe atherosclerotic vascular disease due to diabetes. So albuminuria is almost a surrogate for diabetes. And that is shown on the left-hand figure. You can see that for any level of GFR, people with diabetes or chronic glomerulonephritis or hypertension have much higher event rates than people who have a more quote-unquote benign form of kidney disease, such as tubulointerstitial disease or autosomal dominant polycystic kidney disease. So kidney function and kidney disease and proteinuria are important comorbidities. They do determine or affect outcomes, but they do so because they reflect the underlying disease process. And the underlying disease process that we'll see in our patients is almost always diabetes, hypertension, and microvascular disease. So what do we know about kidney disease and HIV? The story really begins at the almost beginning at the HIV epidemic, where there's a publication of focal segmental glomerulosclerosis in acquired immune deficiency syndrome that came out of Downstate Medical Center in Brooklyn, New York, published in the New England Journal of Medicine in 1984. And this is clearly the first description of what we now know as HIV-associated nephropathy. And we can see in the lower slide, on the left-hand figure, there's a normal glomerulus, and on the right, there's a glomerulus that's sclerosed and collapsed. And in the early days of the HIV/AIDS epidemic, all kidney disease was AIDS nephropathy or HIV nephropathy. But with the advent of effective antiretroviral therapy, prolonged survival, more and more classic kidney disease risk factors like hypertension and diabetes, we see much more indolent forms of kidney disease and, thankfully, much fewer cases of HIVAN today than we did at the beginning of the epidemic. So the spectrum of kidney disease is reflected in this paper published several years ago, but I think it really represents what we see. These authors describe two forms of kidney disease. The first they call non-primary kidney disease, which is really a surrogate for atherosclerotic vascular disease. These are patients who have hypertension or diabetes and microcirculatory disease. And these are patients that, when we first see them in our clinics, they appear normal except for these classic kidney disease risk factors. And over time, GFR falls, serum creatinine rises, and we make clinical diagnosis. With kidney biopsy in this situation is relatively rare. And these people actually do reasonably well for many years. And end-stage renal disease requiring dialysis is relatively infrequent in these people. But of course, there's the epidemiologic risk for adverse events, as we discussed previously. And then there's our patients with what these investigators call primary kidney disease, essentially glomerulonephritis. No vascular disease, but some process in the renal glomerulus. And the classic would be HIV-associated nephropathy. We see scattered cases of poorly defined immune complex disease, IgA nephropathy, Hep C co-infection-associated glomerulonephritis. And these are patients who usually present with advanced kidney disease and heavy proteinuria. They often come to biopsy because of this exceptional clinical presentation. Interestingly and importantly, they're most often of African American race, and unfortunately, these patients often progress to end-stage kidney disease. The good news is, particularly for HIVAN, we just don't see many of these cases anymore because there's a strong association between viral replication in the kidney and HIV-associated nephropathy. And there's clear data that antiretroviral therapy reduces viral replication and actually reverses and certainly prevents new cases of HIV-associated nephropathy. The prevalence of kidney disease in HIV patients is somewhat dependent on the cohort you study. The prevalence ranges between 3 and 15%. The high number tends to occur in patient populations that are enriched in patients of African American descent or African descent. The major causes of kidney disease are hypertension and diabetes, and the relationship between race and kidney disease is very controversial. There's both the combination of genetic factors and there's certainly healthcare disparities, both of which contribute to the predilection for kidney disease in African Americans. If you look at specific HIV-related factors, your patients with chronic kidney disease will tend to be older. They will tend to more likely have an AIDS-defining illness, a low CD4 count, or a high viral load, and co-infection is also a risk factor for chronic kidney disease. One of the questions that's a big question in nephrology related to HIV is how much kidney disease is attributable to the antiretroviral regimen. This slide actually addresses the genetic basis of the racial predilection for kidney disease. These are genome-wide studies performed on patients of African descent with either HIV-associated nephropathy, idiopathic focal segmental glomerulosclerosis, and non-diabetic end-stage renal disease. Abnormal polymorphisms in the MyH9 ApoL1 gene on chromosome 22 is strongly associated with a risk of either of these diseases. It turns out that the ApoL1 MyH9 gene encodes a non-muscle myosin chain that's expressed in specialized cells of the podocyte. And it appears that this may be what we call the two-hit phenomenon. If you have a susceptibility to dysregulation or collapse of the glomerular podocyte, and then have infection in that cell, be it HIV in terms of HIV-associated nephropathy, or perhaps another virus in idiopathic focal segmental glomerulosclerosis, that might be a sufficient insult to cause the podocyte and the epithelial cell to malfunction and the glomerulus to collapse and scar. This may explain part of the predilection of kidney disease to African Americans. It's unclear whether it explains all of kidney disease, and I do think that healthcare disparities play a major role. This next slide addresses the issue of proteinuria or albuminuria in HIV and kidney disease. Mentioned before, testing for microalbuminuria is a standard of care for preventing kidney disease in diabetics. There's strong randomized controlled trials and observational studies that demonstrate that microalbuminuric diabetics are at increased risk for the subsequent development of clinically important kidney disease 5, 10, 15, or 20 years down the road. And that clinically important kidney disease is often end-stage kidney disease requiring dialysis. The standard of care for microalbuminuric diabetics is to begin ACE inhibitors or angiotensin receptor blockers. This slide demonstrates the significance of microalbuminuria in non-diabetics. This is an HIV-infected population, over 17,000 persons who are receiving care in the VA medical system. And these patients are followed for incident coronary, cerebrovascular, or peripheral arterial disease. The graph on the left shows a group of patients who have GFRs greater than 60. So based on serum creatinine, we would not identify these people as having underlying kidney disease. And you can see, going from the white bar to the shaded bar, that the lowest incidence of atherosclerotic vascular disease is present in people with normal proteinuria. The risk rises in the second bar, which represents patients with microalbuminuria, and the risk is highest in patients in the dark bar, patients with dipstick-positive proteinuria. So the best evidence we have is that microalbuminuria in non-diabetics is actually a marker of atherosclerosis, not a marker of subsequent development of end-stage renal disease. And that's true in the general population as well. Microalbuminuria is a marker of atherosclerosis, presumably reflecting inflammation in the endothelial cell. Now, what about viral replication and kidney disease? Clearly, in HIV-associated nephropathy, viral replication in the kidney is necessary to produce kidney damage, and antiretroviral therapy reverses HIV-associated nephropathy and certainly prevents it. The data on people with normal kidney function is interesting but of questionable clinical significance. There's a lot of data that inflammation and viral replication can reduce GFR. That could be measured either by serum creatinine or a novel biomarker cystatin C. And there's also evidence from ACTG trials that GFR tends to increase when ART is initiated in drug-naive patients who begin with low GFR. I want to emphasize that these trends are intriguing, but it's unclear whether viral replication per se, independent of HIV-associated nephropathy, actually produces clinically important kidney disease. We'll have to wait for further data on that topic. What do we know about the relationship between the regimen we choose and the development of kidney disease? Some of the best data come from large-scale observational studies. And here's a summary of data from the EuroSID cohort of thousands of patient-year experience. And this slide shows the relative risk of developing a GFR below 60 based on the antiretroviral regimen. And you can see that tenofovir, indinavir, atazanavir, and lopinavir all are associated with an increased risk of developing low GFR. It's important to emphasize that the major causes of kidney disease in this cohort are hypertension and diabetes, the classic chronic kidney disease risk factors. And this analysis is specifically looking only at the role of the regimen. The risks associated with these drugs are meaningful, but they're very, very small. Only a handful of patients in each group develop chronic kidney disease. Here's a meta-analysis that's specifically focused on tenofovir and changes in GFR. And the study is divided into randomized controlled trials, both drug-naive and drug-experienced, and cohort study, drug-naive and drug-experienced. And you can see that in most studies, there's a very low and statistically insignificant trend for GFR to be lower in tenofovir-treated patients. But when you look at all the data together in terms of a meta-analysis, there's a small and statistically significant decrease in GFR in tenofovir-treated patients, usually seen more in cohort studies than in randomized controlled trials. And I think this data represents what we see in practice. tenofovir can cause kidney disease. It does so rarely, but in large-scale clinical trials, mainly observational, you'll see a signal, and it's usually statistically significant, but of questionable clinical significance. Based on all these data, we have pretty reliable and accurate recommendations of how to screen and follow kidney function in our patients. And this slide is a summary of recommendations from DHHS, IDSA, and IAS. And the recommendations call for a baseline assessment of kidney function in all patients who come to our clinics. That includes urinalysis and estimation of GFR through serum creatinine. We should especially focus on patients who are at a particular risk for developing kidney disease, and that's Black race, hypertensives, or diabetics. And we certainly should assess kidney function prior to initiating treatment with drugs that have the potential to cause nephrotoxicity, tenofovir or indinavir, mentioned in the guidelines. Patients should be screened annually for kidney disease, particularly high-risk patients, those with AIDS-defining illness, Black rate, or the classic kidney disease risk factor, diabetes, hypertension, or co-infection. An assessment of renal function should occur before initiation and during ART, particularly when certain regimens are used, such as tenofovir, maybe the boosted PIs, atazanavir, and lopinavir, also should be included in those recommendations. That's going to allow us to make reasonable decisions about what regimen to use and when it's time to either avoid, dose modify, or change regimens. There's been a lot of interest and some studies about looking for other markers of kidney disease that's not dependent on serum creatinine. Serum creatinine, alluded to before, is very good but not perfect. It's generated from muscle, so people of different muscle masses will have a different relationship between serum creatinine and GFR. And creatinine doesn't always represent the site of injury in the kidney where we're interested in. In terms of drug-associated kidney disease, that's often more focused on the tubule cell or the tubulointerstitial area. So there are a lot of biomarkers that are being tested, but none are ready for prime time. This leads me to conclude that serum creatinine is still the most reliable marker of kidney disease, and we should be following serum creatinine in our patients. This next slide is an example of tracking other markers of kidney function. These data come from the IPrEx study published in the New England Journal of Medicine several years ago. And the study was comparing FTC tenofovir to placebo in about 3,200 seronegative men at high risk for contracting HIV due to unsafe sexual practices. And in terms of renal safety, the investigators tracked serum phosphorus with the hope that a low serum phosphorus may be an early marker of tenofovir-associated kidney dysfunction, also termed a partial or incomplete Fanconi syndrome. So as you can see in this slide, the same number of people developed hypophosphatemia in FTC tenofovir compared to placebo. So it doesn't appear that monitoring surrogates of kidney function, like serum phosphorus, are really helpful in picking up the infrequent case of drug-associated kidney disease. The same can be said for tracking proteinuria. Proteinuria is very useful to screen patients and to follow periodically, but there's no data that monitoring on a regular basis actually identifies early cases of drug-associated kidney disease. Here's new data that's come out. This is data recently published in Lancet with the new drug Quad, now Stribilt. And in this slide, we're seeing the change in GFR in Stribilt-treated patients compared to control, ATRIPLA, or treated patients. And there's an increase in serum creatinine of a mean of 0.12 milligram per deciliter. And there's good evidence that that rise in serum creatinine is due to the effect of cobicistat, which interferes with the secretion of creatinine across the renal tubule, but there's no effect on GFR. The next slide is a similar study, again showing the increase in serum creatinine associated with Stribilt, but now the control group is boosted atazanavir with FTC tenofovir. And again, you see the change in serum creatinine in Stribilt group, but importantly, there's an almost similar change in serum creatinine in the boosted atazanavir. And there's good data that ritonavir, similar to cobicistat, increases serum creatinine not by decreasing GFR, but by interfering with the tubule secretion of creatinine. So we'll remember that when we track patients on Stribilt, we can expect an increase in serum creatinine in the range of 0.1 to 0.3 milligrams per deciliter. And that's due to the effect of cobicistat interfering with creatinine secretion across the renal tubule, not at all dissimilar to what we know and what we've experienced with giving tenofovir with boosted atazanavir. So let me conclude by saying that the HIV practitioners and the primary care physicians are really empowered to identify patients with kidney disease. They do this by tracking serum creatinine and checking for proteinuria. The next challenge is to diagnose the underlying cause. It most often occurs in the setting of hypertension or diabetes, and more times than not, we make clinical diagnoses. The next step would be to initiate therapies to prevent or delay the progression to end-stage kidney disease. That's usually very aggressive cardiovascular risk factor modification, the liberal use of ACE or ARBs in proteinuric patients, an aggressive control of serum cholesterol, smoking cessation, and strict glycemic control. Of course, all these are easier said than done, and that's, of course, a challenge in medicine. But all the evidence suggests that what we're seeing, the link between kidney disease and adverse outcome, is really the underlying disease process of hypertension and diabetes that's causing diffuse atherosclerotic vascular disease and thereby reducing kidney function and or increasing urinary protein excretion. Nephrologists can be very helpful in helping confirm the diagnosis, to address the diagnosis and therapy in atypical cases such as those with rapid falls in GFR, heavy proteinuria, and certainly in all patients with later stages of kidney disease, to risk stratify for complications, particularly in patients who become hospitalized, and to treat those unique comorbidities morbidities or complications that are due directly to reduced GFR, such as secondary hyperparathyroidism, anemia, hyperkalemia, metabolic acidosis. And all of us should pay strict attention to drug dosing guidelines for drugs that are excreted by the kidney, have accurate assessment of our patient's GFR, and appropriately dose adjust such drugs. Thank you very much for participating in this with me, and I hope this presentation has been helpful.
Dr. Winston, that was a splendid presentation. We greatly appreciate the insights and knowledge that you have imparted on us today during your session. And for all of those who have been listening, we hope you found this very beneficial. We encourage you to fill out the CME form so that you may obtain credit for your efforts today. And finally, we hope that this whole series has been useful to you again in 2012. We are hopeful to obtain funding so that we may continue this series of virtual Grand Round presentations on HIV into 2013. So until then, this is Dr. Tagey thanking you for being with us. Have a great day.